You're welcome back to Sunday Breakfast right here on ChannelOne TV, and that beautiful, beautiful music by Kenneth Appiah. We're moving on to our health segment. Dr. Kalsum Zakaria Adams has joined us. Today we're talking about salivary gland disease in the head and neck. Salivary gland disease in the head and neck. She'll be throwing more light on that. But if along the way, you have some questions or suggestions or anything at all, just send it to the WhatsApp number 0204 447 033 0204 447 033. Alternatively, go on our social media platforms, #Sunday Breakfast, and we'll read it right here for you. Doc, good morning.
Good morning.
How are you doing?
Very well.
You had a good week?
Yes, I did. How
Clearly,
are you?
it's a stark difference from like a couple of weeks ago, right?
When she came in looking all exhausted.
Yeah, I can tell.
Yeah.
Whatever that happened this week, more of it. You sound too excited.
Yeah, that's true. Well rested.
Well rested.
Great.
Yeah.
Oh no, I like that.
Great.
No, I like that for you. I like that for you.
Yeah,
You're interested. Yeah.
I think we can go straight into our topic. When we say salivary glands, what exactly is that, or are those?
Okay. So salivary gland diseases, salivary glands, so they are organs, okay, that we find in the head and neck region. So we have 3 pairs of major salivary glands. So when you look just in front of the ear, and then below the ear, there's one of the major salivary gland there, which is called the parotid gland, okay? And then just below the jaw, okay, on either side, is also paired, is called the submandibular gland. And then just below the tongue, there's another one there, which is called the sublingual gland. So these are the major pairs of the salivary glands that you have within the head and neck region. And you have several other salivary glands, which are the minor ones, about 200 plus, that are widely distributed within the gums, the mucosa, the oropharynx, all the way, even down to the respiratory system, okay? So these are when we say salivary glands, this is what it is. What do? They play a very major role, okay, in digestion. They also play a major role in helping us to taste, and their main function is the production of saliva. And to say that every adult ends up producing about 1.5 liters of saliva within the day. So over 24 hours, you produce that much saliva, and it has various functions. So the various functions range from the fact that it acts as a lubricant to help with swallowing. It also helps you to taste the food that you are eating. It starts some digestion of certain food substances within the mouth before it even goes all the way down to the gastrointestinal system and all of that. Now, why are we talking about it? It's important we talk about it because they play a very major role, and certain times people are not aware of some of these diseases when they do occur until it becomes very, very bad. So it's important that we talk about it. And one of it is the fact that, especially the one that I spoke about, the salivary gland that is found just below the ear on either side and then in front of it. That's the parotid. There's something that is, okay, it's even shown on the picture. There's a nerve that goes through it, okay? So that nerve we call the facial nerve.
Okay.
And the facial nerve is one of the cranial nerves of the head and neck. And what does it do? It plays a very key role in helping us to express our face or facial expression. So when you smile, it is your facial nerve that is in action. When you're able to grin, it's your facial nerve that is in action. When you wrinkle your forehead, it's your facial nerve that is in action. Okay, so all of these are functions. And anytime there is something that affects the parotid gland, because the facial nerve passes or courses through this particular gland, and it affects it, you would see it glaring when the patient comes in, especially when it comes to the cancerous diseases that do affect the parotid. So you would see that there will be drooping of the lip. You see that the person will not be able to shut their eyes, okay, and that will come with all of its complications as we talk about this topic. So let me go on to some of the diseases. The diseases are varied, okay. You can have infections, you can have tumors affecting it, you can have some obstructive diseases affecting it as well. We have spoken about some stones. There are strictures as well that can affect the tubes or the Wharton's duct or whichever, the Stenton's duct, which of them, it could affect it as well, and then that may end up becoming a problem that needs to be sorted out. So zoning down to the tumors, okay, so the tumors can either be cancerous or they can be benign. So if they are benign, what you typically would present, the patient will present with would be a lump. So you find a lump just below the ear, okay, and then sometimes just in front of it. That's when it's affecting the parotid gland. So usually people would say that, oh, there's this lump that started just below my ear, but I didn't pay attention to it, and now it has grown bigger over the period, and it has now become painful. Or in certain times now I've noticed that I'm unable to close my, if I'm asked to close my eyes or to shut my eyes, I'm unable to shut my eyes. I'm unable to shut my eyes, okay? So all of these may give you indications that there's something happening in the parotid gland, and it's likely it's affecting the nerve, that's the facial nerve that passes through it. And that is what the patient is presenting with. Certain times we say that most of these tumors that do occur in the salivary glands or the parotids are benign. It means that they are not cancerous, okay? But if you do not present to the hospital at a very early stage, it can stay on, and over 10 years, studies have shown that these benign tumors that started can become cancerous. And when they do become cancerous, it means that we are in trouble. That means that it's cancer that is now would end up affecting other structures that are very close to where the parotid gland is. And the structures there it's a very small area. So the structures there are very delicate, and you may end up having very, very bad complications that cannot be managed if you had presented earlier. So these are some of the presentations that these patients may come in with. So when you talk about some of the risk factors associated with, say, the tumors that do occur in these salivary glands, we can mention the fact that most of them are sporadic. They just do happen, okay? Certain times to some patients that undergo radiation therapy. So some x-rays, they may have taken some x-rays or been exposed to some radiation that has ended up causing the cells within these organs to start to divide and then multiply and then become tumorous, and then eventually they may end up becoming cancers. So these are some of the things that we are talking about. Aside that, aside tumors, you can have some infections, okay? So these infections could end up causing the gland itself to become bigger. But it doesn't mean that it has a tumor. So you need to be able to differentiate between infections and a tumor. Certain times you have autoimmune conditions, that's yourself affecting itself or attacking itself, that will lead to some of these lumps developing in various parts of the head and neck region that may need some or certain urgent care that needs to be done. So what are some of the investigations that we can do for us to be able to assess these salivary gland tumors? So The first thing will be that once you have identified that there's a lump there, or you have identified that there is some facial weakness, okay? Facial weakness in the sense that I'm sure we may be wondering what facial weakness really means, because stroke also would present with, facial weakness, yes. But then when you look at facial nerve weakness associated with Bell's palsy, is different. You can differentiate it from stroke in the sense that for stroke, it doesn't only come with the facial weakness on that side, but also there may be other limb, abnormalities. And then the other thing is that there may be speech changes, slurred speech. So that will help you differentiate facial nerve palsy from a stroke. Also, you notice that in strokes is an upper motor neuron lesion. I mean, these are technical things that maybe when I say it, we may not be able to understand. So let me keep it very, very simple. So in a stroke, you notice that when you ask the patient to try and wrinkle their foreheads by looking up, they may be able to wrinkle both foreheads, on either side, on the left and on the. But then when it is just a facial nerve weakness from Bell's palsy, you notice that the wrinkling on one side will not be there. So yes, so that's one of the things that you can also look at. And then it doesn't come with all the speech difficulties and then the other limb weaknesses as well. So that is one of the things that you can use to differentiate the two. And of course, you have to look at your history as well, and then some of the risk factors that the patient presents with to be able to diagnose each of them distinctly. So coming back to the investigations, so what do you do? The first thing you'd want to do if there's a lump around the head and neck region is to want to examine it as much as possible. Examine it and be able to characterize it. What is the consistency of it? Where is it located? Is it below the jaws? Is it below the tongue, as I mentioned? Or is it just around the ear? Okay, so you would want to look at all of these. After characterizing it, the next thing is that you would want to, based on the consistency, so if it's a tumor we are looking at, then it's likely it's either going to be firm in consistency. So you would want to take a biopsy of it. So a biopsy is you are taking just a little piece of it and then you are taking it to the lab for it to be looked under the microscope, and then the biology would be given you.
So the first phase of the observation is just physical, looking at it.
Yes.
But are there any other diagnostic tools you can use to say, okay, I'm going to scan you with this machine or do this and figure it out?
Yes, so ultrasound is also one of the things that you can use. So you can use an ultrasound to examine the lump where sound system is used to be able to characterize that particular
How about the
swelling.
MRI?
MRI is also possible because it's soft tissue, but then if MRI comes with its own cost implications, okay? So
it's
if
expensive.
you can, exactly. So if you can diagnose any salivary gland tumor with a USG or an ultrasound, I mean, there's no point going to do an MRI. But then there are certain times where, when it's indicated, yes, you go ahead and do your MRI.
Let me just sidetrack a bit. Do we even have like functioning MRIs in Ghana?
Yes, we do. I know for Kolebu Teaching Hospital, yes,
That's
there's,
yes,
yes,
but just
definitely.
and maybe push to show UGMC.
UGMC should also have. And then, we have private.
Okay, so Bank of Ghana maybe.
Yes, we also have some of these private.
Yeah, but like, I'm asking because Rich doesn't have a functioning CT scan.
CT scan.
And I'm sure MRI.
That's unfortunate, yeah.
Wow.
Yeah,
anyway.
that's unfortunate. Because usually, you need some of these modalities to be able to investigate some of these lesions and then properly characterize and then get the diagnosis so that the patient would undergo the appropriate treatment for the particular ailments that the patient may present with. Yes. So back to the investigations that we were talking about.
Yeah.
So doing an ultrasound, yes, is indicated. Certain times you would have to even you can do your CT scan with contrast. Okay, so you can do your CT scan with contrast, and you will be able to characterize if there's any tumor within any of these salivary glands. It also would help you to diagnose if there are any stones in any of the ducts or even within the gland itself. So all of these are ways, and these are, we call them, all of them are imaging modalities that you can use for diagnosing some of these salivary gland diseases. And I was talking about the biopsy. So the biopsy is under histopathology, where you will take a little bit of it and then you take it to the lab. It's looked under the microscope and then the particular diagnosis is given
Doc,
you.
how are you taking the little bit that you're talking about?
Good. So, so there's something we call FNAC, fine needle aspiration cytology. So it's a little needle that you put in there, okay, and then you use negative pressure to be able to aspirate as you move in and out. You're able to aspirate a little, or you won't feel the pain at all. It's close to painless. So you're able to, you know, aspirate a little bit of the cells, and then you take it to the lab. It's put on the glass slab, and then it's looked under the microscope. But then, remember, this is when the lump is covered. The lump doesn't have any ulceration. The lump doesn't have any skin changes around it. So you can do your FNAC. But then in certain times when people do not come to or present very late, in those times, you notice that they may come with some ulcerations, especially when it is cancerous. So when there's an ulceration, then you may not have to do the fine needle aspiration cytology, but rather you would want to do an incisional biopsy, take a block of it, and then take to the lab. Or you may have to do something else, which we call the core biopsies, which is also another needle that you use, but it's bigger than the fine needle aspiration cytology. So that would give you the nature or the biology of the tumor that you may be dealing with. Then the next thing would be that you then would want to plan for surgery for these patients. So depending on the type of tumor, you know, I mentioned earlier that the most common type of tumor for the parotid gland, the one that is just found below the ear and then in front of it, is something we call pleomorphic adenoma. And most of the time it's benign, okay? It is not cancerous. So the earlier you find it, the better. But it will stay there and keep growing. So it can grow very huge. And then, yes, to the extent that sometimes, I mean, it becomes very difficult to be able to tell if the patient has, let's say, literally like two heads, you know.
Oh, I was going to say goiter or something.
Exactly, like yes. So goiters are here,
but that
central,
one is here.
Yes, but this one is just below the ear and then in front of the ear. That is where that gland is. Okay, so there are certain times that if you don't do anything about it, chances is that it will become bigger. The other thing is that it can become cancerous if it is long-standing for a very long time. So you would want to come in for surgery to be done for you. So if it is involving the parotid gland, which is just in front of the ear.
Is that what you call like abscess?
No. So abscesses are infections as well. So an infection that has caused liquefatic necrosis, and then now you have pus collected within a particular space. That is an abscess.
I'm calling it. Like I don't have any idea whatsoever. I don't know where I've seen I don't know where an abscess came in my mind. I'm asking, but it just sounds like something that's like
connected. Because some people think that all swellings or all
abscess.
lumps exactly are abscess. So it's good you mentioned it. Because if it's an abscess, the likelihood is that when you do touch it, it will not be firm, as I mentioned. It will be soft. It will have a soft consistency. It will have an ill-defined edges. It won't be well-defined as you would have in the tumor, which is benign. Okay, so it's important that it's good that you mention. And also another thing is that it could be a swelling, but that is what? A cyst. Okay. So that's also another disease category for all of these salivary glands that we are talking about. Yes.
So obviously, as the name suggests, if there are complications, then it means that you won't produce saliva as you should.
Yes. So if there are complications related, so maybe I should go back to the percentages of saliva that is produced by each of these. So resting, in your resting mood, 70% is produced by your parotid gland.
70%?
Resting, yes. But if it's stimulated, 70% is produced by the submandibular gland.
When it's stimulated, what do you mean?
So stimulated is when you perceive food. Okay.
Okay.
So
okay,
when
like
you
stimulated,
exactly
yeah.
stimulated when you're about to eat, okay, or when you take in any some of these dialogues that will help.
I remember interviewing on the show. We had like what was it called? A naturology,
Naturopathy.
Naturopathy.
Yeah. Charlie some things. He was say some things, but and I remember one time he said that. So, for example, you know, when you use some of these spices and these cubes in the food, that is the allure for like salivation, right?
Yes, yes.
Is there like some
yes,
science to it?
definitely, yes. So definitely when you taste food or when you perceive food, there's a neurological aspect of it where it's the brain will send signals to the glands that, okay, prepare, there's food coming in.
Is it also connected to the whole Sigmund Freud? I don't. Is it Sigmund Freud? Like the bell theory.
Exactly.
So now they ring the bell, they put the food, the dog is salivating.
Yes.
They take the bell, they put the food. That's kind of an interesting theory.
Exactly. Yes. So it's the same thing.
Which of these glands work when you're about to vomit? There's some taste that comes into you.
Yes. So you tend to have. So that's nausea.
Okay.
So you have some nausea associated with it, but that is also, you see, the glands are supplied by, as I mentioned, you have these major ones, and then you have the minor ones all over.
Okay.
Okay. For you to nauseate and then vomit, there's something called the vagus nerve. Okay. It has to do with it's being stimulated behind the throat. Okay. So then you would have maybe some of the minor salivary glands being stimulated as well, because that is where they are situated, and then you end up.
Let me clarify. So I actually meant the Ivan Pavlov bell theory.
Yes.
So it's basically conditioning.
Yeah.
So they ring a bell, they bring the food, the dog is expecting the food. Then over time, they ring the bell, there's no food, but the dog is still salivating.
Exactly.
You know, interesting. I think it's in psychology.
Exactly, it's in psychology. So it's the same theory. Once you perceive food, then the whole brain will then stimulate your glands to start producing the saliva.
So 70% of our saliva is produced when we are asleep or at a rest state?
At rest. So you haven't stimulated it.
Is that why
stimulated in the sense that you have food in front of you.
Okay.
Yes, you have food in front of you, or you're thinking about food. You know, that is all the stimuli that I'm talking about. Okay. But then, so if it is stimulated, yes, major of it is coming from the submandibular gland, and then you have just 5% coming from the sublingual gland. So all of them do have. There is actually a category of salivary gland diseases which we call hyposalivation or hypofunction. Maybe we'll take it another time. But it has to do with diseases that do affect the salivary glands in such a way that they do not produce saliva.
Hey.
Oh, wow.
Yes.
Can you even survive?
Yes. So imagine the functions of the saliva. The fact that if you stimulate or you perceive food, you need it to serve as a lubricant. So patients may come to you telling you that I've noticed that I have a very dry mouth. And then I've also noticed that anytime I want to eat, I find it very difficult. I start eating and the food gets stuck.
Yeah.
Because there's nothing
to
lubricate and then push it down. Right. You get it. So there is a whole disease category that deals with that. But then if you do have a tumor, and usually we don't have bilateral tumors, because I mentioned that there are 6 of them, 3 paired. So if it's affecting just one side of it and you take it out, the others will compensate, and you may not have that xerostomic feeling. So when I say xerostomia, is like you feel the feeling of dryness of the mouth. So you may not have it. But then if it is affecting all of these salivary glands, then you definitely have what we call hypofunction, hyposalivation and hypofunction, which would come with it all signs and symptoms as well that we can discuss.
I feel like one of these days you should deal with it. I'm just wondering life without having to produce saliva.
Yes, yes. So we'll definitely deal with that. Very interesting aspect of it as well. We'll definitely deal with that. So yes, you were
Yeah, I
about
wanted
to say.
to ask whether lifestyle factors such as dehydration, smoking, poor oral hygiene can increase your risk.
Yeah. So yes, definitely. If you are smoking, yes, smoking has been linked to some of the cancers that do occur in some of these salivary glands. Poor oral hygiene. What's definitely would happen is that if you do, there's something we call in salivary gland stone formation. Okay, there's an anterograde theory and then a retrograde theory, where you have, let's say you have some of the food debris within the mouth, and then these salivary glands, when they are produced and wherever that they are located, they need to get to the end point. The end point is usually the mouth. Okay, and how do they get there? They get there through tubes. So each of these major salivary glands have tubes that open into the mouth, and they have the opening is there. It's like a papilla. Okay, so if you have poor oral hygiene and you have a lot of food debris within the mouth, these debris can go in a retrograde function, or they can go in a backward function, and then get into the substances of these glands, and then they form a nidus, and eventually a stone can form out of them. So that is where
sounds very serious.
Yes, so that is where these factors that you have mentioned come in.
Wow.
So
Kujo from Ho is asking you a question, Doc, and he wants to know, can this also increase your high intake of salt?
high intake of salt, no. It has nothing to do with high intake of salt. The only thing I'll mention here is that sometimes you may have to, if patients have saliva hypofunction, you may have to give some sialogogues. So something like lime, there are certain medications too that we can give that will help you to produce more saliva or stimulate you to be able to produce more saliva. But salt, no.
Okay.
Yes. So these are so far these are some of the things that do affect the salivary glands, and patients do present with some of these complaints. And as I mentioned, it depends on the gland that is affected, and that would actually drive the type of treatments that you may have. So if it is affecting the parotid glands, the ones just around the ear, you can go ahead and then do a type of surgery. So usually you would want to conserve it to be conservative if it is benign. Conservative so that you don't end up injuring the very important structure that I mentioned, which is the facial nerve. It's a very important nerve, because imagine the nerve is injured. If it's injured, that means that half of your face will be expressionless. You won't be able to close your eyes. You won't be able to smile. You won't be able to grin. All of that and it's going to be one side. You get it? So it's a very important gland, and it's a very important nerve that most people need to be aware of, so that if there is any disease happening around the parotid gland, they quickly come in for the necessary treatment to be given. Having said this, sorry?
Is it life-threatening?
So it will depend on the biology of the tumor.
Okay.
So if it is malignant, yes, there are certain times, if for a very long time, long-standing, it can move to other parts of the body. So it can go straight to your spine, it can go to the lungs, all of that, depending on where the metastasis has gotten to. And that can be life-threatening. And yes, it can lead to death if it is not treated. Okay. So the other thing is that some people would say that, okay, I had this, I came to the hospital, it was treated, but after that, I noticed that anytime I get stimulated or I perceive food, I start to sweat. Yes, I start to sweat around that area.
Yeah,
so
yeah.
it's one of the complications.
Person should pray about the spirit of
No,
gluttony.
it is not.
because-
No, it is not. So it happens. It's one of the commonest complications of taking out the salivary gland. There's something we call Frey syndrome.
Free.
Frey syndrome.
That's an F-R-A-Y.
No, Frey.
E-Y.
Okay, Frey syndrome. So it has to do with healing after the surgery. And so now whatever that was stimulating the saliva production has healed onto your sweat glands instead that supply the skin over the temple and then over the region. You get it? So now anytime you perceive food, they tend to sweat on that area. So it's one of the complications that can arise. And if possibly you may have undergone the treatment and this is happening to you, please, this is not spiritual. Just come back and you'll be assessed properly and you'll be given the right treatment that needs to be given so that you don't end up getting too anxious for that. It does happen as one of the commonest complications of either surgery around the parotid gland or even trauma. Sometimes you may not have even had surgery, but you may have been involved in some accident of some sort and then it led to some soft tissue injury to the region, and then during the healing process there was aberrant innervation of the sweat glands in that region, and then now you end up having, instead of you salivating when you are perceiving food, you rather would sweat. On that region.
Interesting.
Yes.
Kuja from Who has sent another message. He wants to know if you normally have a lot of saliva in your mouth at a go, is it a sickness and can it be treated?
Okay, how much saliva is a lot? That's the question to ask. So it depends. If it doesn't have any different taste, okay? So certain times, because of infection, so if you have pus, as you mentioned, an abscess related to any of these, you may end up having the pus being poured inside the mouth together with saliva, and then it becomes very voluminous, okay? So in those times, if you have, foul smell of the discharge, or is there a discharge associated with your salivation and it's foul smelling, yes, you need to quickly come to the hospital for it to be sorted out. But I don't think there is a lot or too much saliva in the mouth, because
Desla wants to know if it can cause bad breath or halitosis.
Okay, so bad breath or halitosis, basically tumors will not cause that. But if you do have a superimposed infection on the tumor, which is affecting the mouth directly, yes, you may end up with halitosis. And yes, that is very possible.
All right.
Coupled with some poor oral hygiene, yes, you can end up with halitosis.
Doc, always a pleasure. Thank you so much.
Thank you
We've learned
too
a lot.
for having me. Thank you too.